The producer has no financial interest. An 86-year-old grandmother came to me worried and upset about her worsened vision after the cataract surgery she underwent 2 weeks back. I realized that the only option for her phakia would be a scleral fixation of IOL, considering her poor corneal status and absent posterior capsule. But the greater challenge in front of me was her inability to withstand a prolonged procedure or another depressing result. Scleral fixation of IOL is indicated in cases of aphakias with absent, inadequate or improper capsular back support. An ideal method stabilizes the IOL in the ciliary sulcus without any tilt and avoids damage to ocular tissue. Scleral suturing of IOL was first done by Malbran et.al. Then Louis J.S. popularized the Abexterno technique. Here, railroading of a straight scleral fixation needle with suture is done through a hypodermic needle within the eye. Newer modifications are sutureless scleral fixation and glued IOL techniques. Here, bimanual handshake technique is used by means of specially designed microforceps. The haptics of the 3-piece IOL are exteriorized and scleral tucking is done. But there are chances of haptic slip, damage and breakage, leading to IOL dislocation and drop. Increased manipulations increase the complications like infections, macular edema and retinal detachment. Haptic exposure is a late complication. In this video, we are explaining a new simple technique of scleral fixation of IOL which is less manipulative and minimum time consuming. Materials used are 26 gauge 1.5 inch needle, 10-0 Prolene with a straight needle at one end and a curved needle at the other. First, the straight SF needle on 10-0 Prolene is docked into the tip of the 26 gauge 1.5 inch needle outside the eye. This is now passed through the temporal scleral bed across the posterior chamber and emerges out through the nasal scleral bed exactly at 180 degrees. The SF needle with a suture is retrieved. Another straight needle on 10-0 Prolene is docked into the tip of the 26 gauge needle to retrieve it from the temporal bed. The sutures are then hooked out through the superior tunnel, cut in the middle and tied to the haptics of the IOL, and the IOL is placed in the ciliary sulcus without any tilt. Moving on from the animation overview to the actual demonstration of this technique. Ensure a soft globe before surgery. Under peribulbar anesthesia, conjunctiva is reflected from the limbus near 3 o'clock and 9 o'clock positions. Adequate cautery ensures good hemostasis. A partial thickness scleral tunnel with 2.5 mm width is created on either side. Cutting the roof of the tunnel at the distal end creates a right angle triangular flap. The length of one straight needle on 10-0 Prolene is reduced to half for easy manipulation and is docked into the 26 gauge 1.5 inch needle. This is passed through the lower portion of the temporal scleral bed, 0.75 to 1 mm posterior to the limbus, advanced across the posterior chamber parallel to iris plane to emerge at the upper portion of the nasal bed. The straight needle on 10-0 Prolene is retrieved. Another straight needle on 10-0 Prolene is docked into the tip of the 26 gauge needle and is withdrawn from the eye. Now two sutures are traversing across the posterior chamber with one curved needle and one straight needle at the ends on both sides under each flap. A 6.5 mm superior sclerocorneal tunnel is made. Here the tunnel of the previous surgery is opened. The sutures are hooked out. Cut in the middle and are tied to the corresponding haptics of the IOL. Each suture is knotted to the haptic eyelet once, and then the suture ends are knotted together 7 times over, so the knot becomes easy as well as secure. Next, the IOL is introduced into the eye and placed in the ciliary sulcus. Prolene ends are made taut. Now the curved needle is passed through the scleral bed and tied to the other suture. The same is done on the other side. Scleral flaps are reposited and sutured. And the conjunctiva is repositioned. Advantages of this technique are: here, there is only a single passage of needle even for double suture fixation. There is minimum manipulation, lesser surgical time, and therefore minimum complications. Sutures are passed exactly through 180 degrees, so there is no chance of lens tilt or decentration. Since the learning curve is very short, most surgeons can easily adopt this technique. Caution: removal of all lens matter is a must for this procedure. A thorough anterior vitrectomy prevents vitreous incarceration. Avoid needle passage exactly through 3 o'clock and 9 o'clock positions to prevent injury to the long ciliary vessels. Keep the sutures at 0.75 to 1 mm posterior to the surgical limbus. More posterior suturing will result in vitreous incarceration, more inflammation, and unstable fixation.
Asato ma sadgamaya, tamaso ma jyotirgamaya, mrityorma amritam gamaya. Asato ma sadgamaya, tamaso ma jyotirgamaya.